Many of you know the healthcare system is going through massive change again. We thought we were going through change a few years ago. We're in the midst of significant change again. Interesting, a lot of it is geared towards improving patient outcomes, improving the patient and family experience. A lot of legislation around that, a lot of carrots and sticks along the way around funding reform. If you're going to do some certain things, you're going to be rewarded. Hospitals, community, CCAC, and others. It's very complex. It's causing a lot of unrest in the system, and we all feel it. If you haven't felt it, you will feel it in the next few years. But it is geared to making the patient and family experience better. That's the rationale, and we'll see where that gets us. We're quickly moving from a provider-driven system, which is pretty well all of us, to a consumer-driven system, and that's happening all across the world. The baby boomers are coming. They're in the system. Their parents, our parents, some of us, I'm older, but some of our parents are in the system. And we and they have very high expectations of the health system. It's going to push us in certain areas we probably have not seen before. We will need to adjust. We're already adjusting. But some things we shouldn't change. Some things are well-founded, especially in nursing. The high quality of care that nursing schools, education provide is second to none. But I think we do have to adjust in terms of how we're going to look after a very, very highly expected population. And there's a lot of young people in the crowd, if you've even here, and they have other expectations. I don't have an iPhone, but they want stuff on their iPhones, on their Blackberries right away. They're not going to wait for the doctor to tell them what their test shows a year or two from now, 5 years from now. They want it at the same time the physicians or the nurses get it. So that change is coming as we speak. Google and Apple are at the forefront of that, and they are making huge strains. So we have to prepare for that, and I think days like this help bridge the generation gap to say what is actually happening out there in the other parts of the world. We sit in silos a lot in our organizations and other places, and we tend to forget that there's a lot happening out there. And today, more than ever, nurses, I know there's more nurses in this room, but certain nurses are positioning themselves at the leading edge of change. They're at certain tables, highly influential tables now, nurses are there, in government, in administration, in a lot of decision-making roles. And they are, and we are trying to influence positive change for our clients, our families, and our patients. So as we journey through this change with our patients, we never, I don't believe nurses ever lose sight of the privileged role we still have within the system. In many settings, in hospitals and universities and colleges and in the community, we have a very privileged role to impact change, positive change. And nurses in all settings, and I think I said this last time I was here a few years ago, is that we're getting much better at analyzing outcomes, researching solutions, and transferring that knowledge into practice, which is what really today is really all about, transferring knowledge into practice.
We're looking at not just about wound care per se, but it's always about the holistic care, looking at the whole patient, not just the whole on the patient. And this is when I was in China doing a lecture tour there, one of the nurses brought me to see a patient. The first question she asked was, well, I got this necrotic area. What should I do to debride this area? So I took a look at the patient. Well, this individual is very, very sick, and I don't think she's actually going to survive. Looking at some of the documentation and chart, so it's really looking at the quality of life and how we can provide better palliation for individuals who may require comfort measures and symptom management.
The NICU at KGH has been randomized as an intervention site. What that means is that we have implemented family integrated care, or FICARE, throughout the entire unit and approach eligible families to obtain data related to the outcome of their babies and the experiences of the parents while in the FICARE program.
Currently, there are over 200,000 Canadians living with a cardiac rhythm device. And as you can see at the bottom of the slide there, the Cardiac Care Network has actually reported in the last 2 fiscal years over 3,000 devices being implanted per year. So that's important. They've become an essential component in the treatment of arrhythmia, heart failure, and advanced cardiovascular disease. And in addition to the advancing technologies from a device perspective, there are also expanding clinical indications for device implantation.
The impact of electronic implementation on clinician workflow and the likelihood of the interim hybrid environment suggests the importance of introducing order sets prior to this type of intervention and the importance of awareness of resource needs to support this stage of transition.
The College of Nurses of Ontario agreed to release to us all the email contacts for all newly registered practical nurses who had agreed to allow in your registration. Remember, you can check off, can researchers contact me? So we had a potential population of just over 3,800 newly registered practical nurses. We sent out the survey and we had a response rate of about 30%, so over 1,000 or over 1,100 participants in this study. The average age was 37 years old, which is much higher than it is usually for registered nursing, new registered nurses, and that's typical for practical nurses. And we had both Canadian and internationally educated participants in the sample.
So I'll give you some background on complex continuing care. So our patient population, it has a large proportion of patients who are at very high risk of getting pressure ulcers. So this is probably one of the highest risk patient populations that are out there as far as risk for skin breakdown. So our continuing care reporting systems data from the Canadian Institute of Health Information showed that St. Mary's of the Lake Hospital site had a pressure ulcer prevalence rate that was quite a bit higher than the average prevalence rate of similar care populations across Ontario. So this precipitated a look at our skin care processes, our risk assessments, and a focus on pressure ulcer prevention.
Delirium can affect all of us, but is more common in the elderly, and it certainly can be critical. Most common causes of delirium in hospitalized elderly are UTIs, pneumonia, and dehydration. So for our pilot project, we used two tools. The first one was the CAM, which is the confusion assessment method, and that tool was used for screening for delirium. And the second tool was the handover tool. And as you can see, handover is just an acronym for all of the things that we needed to put into place to manage or prevent delirium. So why does delirium matter so much? Well, 15 to 60% of hospitalized seniors develop a delirium. So that's a pretty high number. It's misdiagnosed 70% of the time. Delirium causes a number of symptoms that are often mistaken for dementia. It's a medical emergency, but the good news is it's reversible if you catch it soon enough. But if it's not treated, it can really result in poor outcomes. So it can extend hospital stays, cause significant functional decline. It can cause increased use of chemical and physical restraints, and ultimately death. So art groups can be extremely beneficial in recovery from mental health. So through self-expression, providing a catharsis, or sort of a survival strategy. So a lot of times people talk about just getting stuff out of their head and how important that can be. It's also helpful for self-discovery, so developing insight into illness and being able to explore emotions, particularly those emotions that are sort of dark or difficult emotions to experience. In terms of spirituality, so spirituality being sort of your sense of your place in the world and how you relate with the world, and what's, how you fit. And so for many of our clients, the ability to create hope and to participate in meaningful and purposeful activity is really important.
And in 3 years, there were 18 reported unplanned extubations, knowing that we might have missed many if they weren't reported. So 50% of those kids actually needed to be reintubated. And just as the literature showed, 61% of them were less than 1 year of age, but even more distressing, 50% of those kids were less than 8 weeks of age. So that's a significant implication for those kids. Almost 90% of the kids are orally intubated, and I think it's unit culture if you're orally versus nasal intubated. But this did have a significant impact in our ICU at GEO.
Overall, the 3 prodromal symptoms that were associated with increased risk of cardiac event were chest discomfort, shortness of breath, and unusual fatigue. Women reporting one or more prodromal symptoms were more than 4 times more likely to have a major adverse cardiac event within 3 months to 2 years as compared with women who reported none. So what does this mean? While there appears to be similarities between men and women, the frequency and clustering of prodromal symptoms are different between the sexes, and this merits further investigation. The prodromal fatigue and anxiety were the most prominent symptoms reported, which means clinicians should really assess for prodromal symptoms. Prodromal symptoms may predict acute symptoms in the acute phase of an acute coronary syndrome.
So from a population level, I'm interested in people with psychiatric disorders in the community. So these are people that are not hospitalized. These are, often our family members, our mothers, children, aunts, uncles, friends, that kind of thing. And psychiatric disorders are quite prevalent in this population. 1 out of 3 Canadians report a lifetime mental or substance use disorder, and that's from Stats Canada data from 2012. And within the past year, 1 out of 10, or 2.8 million, report a mental or substance use disorder. And the interesting thing about psychiatric disorders is they often don't occur in isolation. Many people have multiple disorders. They can have depression along with an alcohol use disorder. So it's important to note that, because often our patients are struggling with multiple comorbidities. We know that females have higher rates of mood disorders and anxiety disorders, whereas males have higher rates of substance use disorders. From a research perspective, I'm going to continue to monitor this problem. I've expanded my research to look at other chronic diseases. I'm really interested in not only cardiovascular disease, but also cancer, chronic respiratory disease, diabetes. And I think we need to utilize these population-level measures, because the majority of people suffering from mental health disorders are in the community. And I know that psychoactive medication use is just the prevalence and the use of it is just increasing day by day. So we need to address this problem head on.